I'm really hoping that this session will be interactive because this is a new type of talk I was challenged to give, and I've tried to put it in a context of different types of problems that we face in the neonatal intensive care unit and how MRI may help us and in that way help us to improve our baby's outcomes. So when I think about how to do this, how to improve outcomes, I'm going to talk around two main conditions, that of term encephalopathy in the term-born infant and that of preterm birth. I won't today touch on IUGR, but I think it is also a very interesting area. The big question in these babies that we care for is there been any impact on the brain of these two situations? And the only way to know that is to be able to define any brain injury or define any alteration in brain growth and development. And why do we want to do that? And there is two key reasons, and I will try and touch a little bit on both. The two key reasons are, if we can identify what is going wrong in the brain early, then we may be able to offer neuroprotection while a process is occurring. The second is that, and this is what is focused on a lot and we will touch on, is that if we can define an injury, then we can start to understand what sort of rehabilitation we should be offering. And I know in the neonatal intensive care unit world, we use the term early intervention all the time. But really, once we know a baby has brain injury, we really need to talk about rehabilitation like we do after brain injury at any other time of life. And we can't talk about that unless we know what we are rehabilitating. Our early intervention services are often more surveillance services than they are directed therapy for rehabilitation. And we need to start to change that by defining the injuries we are treating. So those are the two things, because if we do these two things, protect the right brain and provide the right type of rehabilitation, then we will improve outcomes. This is where MRI comes in. It should be able to be better at defining injury or altered development. So let's start with the types of conditions that MRI, and let's look at where the gap exists at the moment in our clinical field and how MRI, particularly if it's very accessible and available in our neonatal unit, may improve outcomes. So this is actually a slide from Mariana Thoresen. This is actually a Scandinavian term-born baby who's looking very confused about why they've come out into the world when it was actually pretty nice where they were. And as we all know, that the day you're born is the happiest day in your parents' life and the riskiest day in your own life. Why? Because of this condition of so-called neonatal encephalopathy. Now, what does that mean? Well, we know for us in the room, if any of us were encephalopathic, even after long flights across the world, that we'd probably be a little bit disorientated in terms of person, time, place, right? But we know that doesn't work so well when we ask our babies, could you give me your name, your date of birth, where you are? You know, they're not as responsive to us about all those things. So we have to try and understand this condition by observation. We know it affects between 2 and 6 per 1,000 live births, and so you can do the math in your own delivery area. If it really is in excess of 20,000 deliveries, one could be expecting you to be seeing at least 120 or 100, 120 of these babies at least in a year. We know that even with hypothermia therapy, between 15 to 20% of these babies will die, and that a quarter of the survivors will have significant disability. Often out in the community, where over half of these babies are born, it will be a nurse practitioner, a general pediatrician. Please come in. There's some seats up here if you are not too There is a nurse practitioner, a general pediatrician, or a neonatologist who may be at the scene when the baby is born. And that because of the nature of the disorder, that often serial clinical examination is the thing that is needed, because this process is one that is often in evolution in terms of the nature of the brain injury. The causes of neonatal encephalopathy are not just hypoxic, ischemic in nature. We know that there are other contributing factors, and so it's important to bear this in mind when you see a term-born baby whose behaviour is abnormal, that although the biggest contributor is a lack of blood flow or oxygen around the time of birth, that there can often be other causes, and the second commonest cause is actually stroke. The commonest time in life to have a stroke is the first week of life. And if you are not seeing a baby with a stroke for every 2 or 3 babies you are seeing with so-called standard HIE, then you are missing them. And we know that we miss over half of the strokes that occur around the time of birth. So you have to have greater surveillance for those strokes. If you look at the other causes, and we spend a lot of time looking at the developmental dysplasias, the dysgenesis, the metabolic infection, and really they are smaller contributors than stroke and hypoxic ischemic injury. So how do we diagnose this condition? We diagnose it by clinical exam, right? Although we cannot ask them what their name is and what date they were born, we look at these factors around their level of consciousness, their amount of activity, their tone, their reflexes, and some autonomic functions. Now it's interesting because all of the trials focused on the moderate and severe. You had to have moderate or severe neonatal encephalopathy. So you had to be mainly obtunded or stuporose with decreased or absent movements, a lot of hypotonia. So you had to be pretty significantly impaired to qualify to go into the therapeutic hypothermia trials. Whereas these babies who may have a hyperalert state, a weak suck, some distal thumbing, they may have their hands pulled in a little bit, they are not regarded as abnormal enough to be considered for cooling. How do we cool? This is another wonderful creation out of your country, the critical blanket, which we adore because we can wrap our babies in it. It's servo controlled for the temperature to go to 33.5 degrees for 3 days. And at that time then the babies are rewarmed. The reason we love this blanket is it keeps very tight control of the temperature, but also the parents can hold the baby because they are in the wrap versus the blanket. It also allows the territory of the head for us to put on neuroinfrared monitoring and EEG monitoring. Does cooling work? 13 randomized controlled trials, close to 1,500 babies across 8 different countries, and yes, very consistent findings here on this Cochrane plot. A 25% reduction in the chance of death or disability with hypothermia. Absolutely dramatic impact. Number needed to treat 5 to save a life or prevent disability. Importantly for us when we were designing these trials was we were very, very worried we would have more survivors, but those survivors would be disabled and that we would just be pulling people back from the brink. And we have found, as you can see here, an improvement in terms of nearly 35% reduction in disability in survivors. So not only were we having more survivors, but the survivors were less disabled. So that's great. It's a great therapy. It works really well. Then the question is, what about those kids with the mild encephalopathy? Would they benefit from the treatment as well? Why don't they get offered this incredible treatment as well? And they were not included in the trials. So we have no randomized controlled trial data to support them apart from a very small number of babies that were included in 2 of the trials. Does it even matter? What about those mild babies? Do they have any problems long term or are they completely fine? Well, if you look at the very small amount of data that exists on these babies, this is data from the Dutch, when a small group of these babies that were followed up to 9 years of age, and it showed a lower mean IQ, increased thought problems, and worse motor assessment. Very recent data from the Cork group showed in 53 infants with HIE and 30 controls followed up to 5 years of age, and they compared the SARNAT grading here, the modified SARNAT, mild, moderate or severe, against a comparison control group. And this is what has often been lacking, the comparison control group. And what they showed, as you can see here, is that infants with mild HIE indeed had lower full IQ scores, and you can see this is 22 points lower than those without HIE, and in fact the mild and the moderates were almost identical. They didn't differ from each other. But let's remember, these babies probably did get hypothermia, these babies did not. But 5 years ago, not many of them got hypothermia at all in Cork. Well, I'm a really good person at examining babies, so I can tell a difference. The more I've learnt about this, the more I've learnt I can't, right? So this is actually data that was published out of the randomized controlled trial, where they looked at the babies who, when the exam was done by a neonatologist, they didn't qualify for the trial because they were too mild in terms of their encephalopathy. So when they followed those babies up just to discharge, not even into early childhood, 7 of those 60 with mild had an abnormal exam at discharge, 5 had seizures, 6 had qualified to get an MRI and they were all abnormal, and 1 of those infants died. So they were too mild to be offered the treatment, and yet 20% of them had pretty significantly abnormal outcomes even by the time of discharge. So what are people around the world and around the country doing with these mild babies? And this is data that was published from the Californian NICU network, looking at 61 different NICUs in California. And the size of the bar relates to how many babies they called overall in a year, and with mild encephalopathy. And when it's blue, it means they got called, and when it's red, it means they didn't get called. So on any single day in any one of these NICUs, you could come in as a mild baby and you could toss a coin depending on who was on, what they believed, what they saw when they examined you, what their underlying belief system is as to whether you would get called or not. And overall, if you look in the British, the most recent British data that was published from their registry, 75% of these babies are now being offered cooling treatment, but it's not universal in any one place for any baby. What do the guidelines say? So the guidelines are here from the American Academy of Pediatrics. They are strictly the trial guidelines. So they are exactly what the randomized controlled trial said. So in other words, you have to be term, you have to have a risk of being, having a lack of blood flow at the time you're born, and you have to have moderate or severe encephalopathy by some systemized scale. So I found that really difficult when I started in Boston, and I was like, you know, I think that's pretty tough. What happens for the big 35-weeker that comes in? What happens for the baby who's sort of mild to moderate, kind of fluctuating? So we softened our criteria and we said, let's still have criteria, but we'll make them softer, and let's monitor who we're cooling and what their imaging looks like to see if we are really treating a lot of babies who have no injury. Because if we're treating a lot of babies with no injury, then we should stop, right? Because we don't want to be taking a baby away and putting it in a blanket for 3 days and doing all these things to it if there's no injury, right? How can we identify whether the injury is present or not? So this work was really carried out by Brian Walsh, one of our fellows. We screened 136 babies for hypothermia during this period, and most of these were between 2013 and 16. We didn't call everybody, despite popular belief that we call everybody we screened. We didn't. We did, however, call 95 of those babies. And out of the analysis, subsequently I'm going to show you, 6 of them were excluded because 3 went on to need ECMO and 3 had alternative pathologies, just to emphasize that not everything that walks like a sheep and bars like a sheep is a sheep, right? Sometimes you have to wait to see. So there were 89 babies that are in this analysis, and you can see that over half the babies had mild neonatal encephalopathy. The milder babies are more common, right? They're the more common group. So when you look at the demographic characteristics of the babies, you can see they don't really differ in anything related to, you know, their characteristics of their gender, their gestation, or the way in which they were delivered. And as you can see, about just over half of our babies we called are inborn, but 40% come from outside of our hospital. Most of these babies universally obviously required some sort of resuscitation. You can see the pHs there, that the severe group, and you'll see this as a group, do differ a little bit in that they tend to have the lowest of the pHs in basic cess, but there wasn't really any other significant differences. When you look at those that would have met the AAP criteria, though, 0 obviously of the mild babies would have, and 70% and 83% would have, even in our moderate and severe by exam, because they were missing the other criteria, such as they would have been 35 weeks rather than more mature. What did we find when we did the MRI scan in these babies? When you looked for the presence of any abnormality on their MRI scan, and this was the MRI scan that was done on day of life 4, you can see the presence of abnormalities in the mild babies, the moderate babies, and the severe babies didn't even differ. I'll show you in just a minute. But you can see that nearly 80% of all the babies had some sort of injury. So immediately we knew we don't seem to be over-treating the mild babies because the mild babies have got a lot of injury.
When was it done, the MRI?
Day 4, day of life 4.
And this was a standard MRI, 3-Tesla MRI?
Correct. What kinds of abnormalities did they have? Maybe the mild babies all had a little tiny spot or dot, not something any more significant, and the moderate and severes had more significant injury. So to be systematic about it, and this was all scored blinded by one of our neuroradiologists who knew nothing about any of the clinical courses. And he outlined the types of injury, but he also scored them on the Barkovich scale in the classic forms of basal ganglia or watershed injury, and looked at the severity. And the standard severity here you can see is that zeros are essentially normal, or believe it or not, in basal ganglia and thalassemas, you can still have an isolated focal cortical infarct and be ranked as a 0, actually. But anyway, you have to be pretty bad to be up here in what is regarded as the moderate to severe abnormalities. So these are pretty significant abnormal signal in both the thalamus and the lentiform, or in the anterior and posterior watershed, not just one or the other, or more severe than that. So these moderate to severe lesions are highly clinically significant. And this was the fraction of the kids in the 3 groups that had moderate or severe abnormality. So the mild encephalopathic group did not differ from the moderate group and did have less injury than the severe group. But you can see that around 25%, or 20 to 25% of these kids had moderate or severe injury. So why is this? The only difference that's significant is to the severe. The severe had more significant basal ganglia injury. Most of the mild and the moderate was still in, it was a more watershed predominant lesion. The severe injury dominated the basal ganglia, the severe basal ganglia lesions. So the severes are still severe and they're still bad, even though they were all cooled. They still have a predominance of necrosis in this basal ganglia area that is very hard to intercept. But what is happening there? Here's some examples here of a mild baby. So here is the diffusion weighted imaging on the top on day 4 and day 10, and here is the T2 on day 4 and then day 10. And as you can see in this baby, there was a posterior predominant with a very small anterior lesion, but you can already see some of the periventricular white matter as well as the watershed lesion. And then you can see now on the T2 the start of the dissolution here within this region here, in particular posteriorly, and a little tiny subcortical infarct here in the anterior area. Is there something wrong in Boston? Are we just really bad at examining babies? Or do we just have a lot of mild babies that happen to have injuries? So we compared the rates that were documented in other MRI studies for those with abnormal findings across the small numbers that have been reported or had abnormal outcomes. And indeed, around 30% of these kids go on to have significant risk for significant neurodevelopmental disability. So it's not like we were overcalling something that was different from the literature. So what happens if you know, some people have said, well, just start cooling in these mild babies and maybe stop early if they look good, because maybe it was a soft call, you know, you didn't really need to cool them. So this is one recent study that was published in 10 babies with mild encephalopathy where the cooling was stopped early. But then they went on to do MRI and spectroscopy within 2 weeks. And what they found was that when the cooling was stopped early, due to this rapid clinical improvement, half the kids had injury on MR, and 2 of them already had abnormal outcomes at 2 years. So it's not so surprising maybe that our clinical exam is limited. And it's limited for 2 reasons, I think. One is the baby, right? We know now, because of all of our studies on seizures, that 90% of the time that a baby is having a seizure, we can't tell they're having a seizure, right? They just don't do anything that shows us clearly they're having a seizure. So is it any surprise that they can have brain injury? And when we examine them, we think they look pretty good, but actually underlying that is a lot or some type of injury. Do we think that it's our fault as well? Yes, I think it probably is. I think this is a subjective examination. There is nothing objective about it. No one has yet done it, and we've started to do videos of the exam, because I'm sure if I video the exam and what I score it at and I show it to my 4 other colleagues that I work with, each of us would score the exam, the same exam, slightly differently. So we have 2 problems. We have a baby, and the other problem with the baby is that we don't know when they had their injury, if they had an injury, and we don't know what the injury is. And then we have ourselves. So it is like a setup for a lot of challenge to know who to offer this treatment to. Does this treatment work in mild babies? Well, in the animal data, in the lamb data, which I'm always very proud, it was all done in New Zealand, and New Zealand sheep. You see, I got a thing with sheep. But anyway, it was very clear that in the sheep the babies who did not benefit were the most severe babies, and that I think is what we still tend to find in our human population. The babies who benefited most were the mild babies, because those babies had the longest window before apoptosis was activated. And so these mild babies, if you ask someone like Alistair Gunn, should we be cooling these mild babies? He goes, why wouldn't you? Because those are the babies who may benefit the most. The reason we haven't is because we're like, well, they're not that bad anyway, because they don't cause a problem to us, right? We see them. Hey?
What are you losing by cooling as early as you're saying?
Well, we separate a mother from their baby for 3 days. We often have to place lines because we don't feed them, right? So people will argue it, and it's uncomfortable. The milder babies will tell you they are uncomfortable. So we use low dose morphine alongside the cooling. So there's a lot of stuff. It's not a normal. Whereas if you examine them in your triage area and you say, they look good, they look really good to me, then you will discharge them up to the postnatal ward to be with their mother, and you'll think everything is fine.
The data you are presenting is much stronger than what I'm losing in 72 hours.
Yeah, I agree. I compare it sometimes to people you are worried about sepsis, you're worried about an infection, so you give antibiotics, right? Because for the 1 in 1,000 babies that you may prevent an infection in, you're going to give antibiotics to 999.
It's a question of communication, how you present it to the parents. But there's no question in my mind.
Right. And no one has looked at the babies who were considered for cooling but not cooled by MR to see. So the question is, where and how could MR help us to define what we are doing? Maybe what we have been doing is at 24 hours, if we really think it was a soft call, that the baby is better, if the EEG has been very reassuring, we put the baby in the scanner at 24 hours. And this is easier to do if you have a scanner on your unit, right? If the scan is completely negative at 24 hours, then we feel comfortable to start rewarming. And we are following those kids up, and so far our repeat scans, which we do at 14 days, have never shown any injury. But that is our only way of intercepting. You have to have all three things normal: your exam, the EEG, and a negative MRI at 24 hours.
To be the devil's advocate, do we know what would be the MRI signals, abnormalities in normal kids that would be?
Yes,
that
that's a
would be
very good question.
cool?
And I'm so glad you asked that, because I didn't plan to do it for this reason. But 5 years ago, I embarked on a study at WashU where we imaged 150 healthy term-born babies because we needed a control population for fetal heart rate abnormalities. And out of those 150 babies, we only found abnormality in one baby.
I want to repeat my question. You did not hear the second part on babies that would be cold. In other words, did we take neonatal lambs, we cooled them, and we checked what happened to their MRI?
So the fetal lamb brains, we did do an MRI, and it does show.
In normal lambs that would have been cooled.
Oh,
But
you
I'm
mean
saying-
as right? You're
I'm
saying
here that when you have 60% of your cooled babies with mild encephalopathy
Yep.
that have abnormalities, and it's the same number as the ones who have moderate encephalopathy, and it's the same percentage as the ones who have severe encephalopathy, I'm wondering if it's not the cooling.
right. So I can show you some data. Let me. It's coming down later. I will show you the data from the randomized controlled trials who all did imaging, and it will show you the reduction in the severity of the lesions across the board with cooling compared to those who were not cooled. So the randomized controlled data is the best data that we have, and it shows that it reduces the MRI injury in all of these babies. I think the problem with the encephalopathy scoring system is it is a subjective scoring system, and the timing and the nature of the injury in the baby and the fact that the baby has difficulty telling us what injury they have by their exam means that we are very limited in detecting these babies.
And how is the inter-observer correlation
For the
MRI?
Oh, MRI is very high. So we have done that. It is in experienced readers. So we are like over 90% in terms of our inter-rater reliability by systematic scoring. So it is good to have a systematic scoring system, and it's good to have trained readers. I do not think that's always as high but it is way better than ultrasound, for instance, way better. So why and how should we image? I think for these babies, you really want to confirm what your underlying diagnosis is. I am fascinated about getting one of these magnets in place in our unit because no one has come down to properly delineate the timing of injury for these babies. And we know that we make a big difference, right? We reduce the risk of death and disability by 25%. But why does it work so well in some babies and not so well in other babies? Maybe some of this relates to the fact that maybe this baby was injured 24 hours before the baby was born. And we have no way of telling that at the moment. You want to really define whether there's any injury there, and is hypothermia therapy therefore indicated in this population? And then, of course, the nature and extent of the injury is important for the family if you can provide better prediction of the long-term, and I'll show you data around that, and what early intervention services or rehabilitation services are needed. So let's just talk about other imaging modalities. Why am I so MRI-centric? Well, ultrasound is useful. It's bedside. It's the most commonly used neuroimaging method in term encephalopathic infants, and you will pick up. We were talking about an agenesis of the corpus callosum. There are a number. We had this large study of over 4,000 babies in the US, and around 2 to 4% of them there was a dysgenesis, some of which was agenesis of the corpus callosum picked up that hadn't been picked up on fetal ultrasound. So it's very useful, but for specific forms of injury it has a low sensitivity. So here is a comparison of a baby with basal ganglia injury here. You can see actually it's very extensive global injury, but the basal ganglia stands out. Here is the ultrasound imaging. People that are used to ultrasound would see that this thalamus is swollen and that there's loss of the ventricles. all suggestive with this abnormal signal that this is an extensive injury. But many radiologists would not know that this is profoundly abnormal and would report it as, it's slit-like ventricles, not sure that there's really profound injury, whereas clearly there was profound injury. What about CT scanning? You don't have to consider that here, but many people do. And really, again, I'll show you there's pretty low sensitivity for important forms of injury in the deep grey. And we still have concerns over the risk of radiation for cognitive deficits, some of the work which came out from Israel. So here is a comparison that Stephen Miller did between CT and MR. CT and MR are both done on day 3 of life. And you can see that maybe these are hypo-intense because they should be the same as the cortex, but very clearly visible on MR. And MR also picking up the area of the cortex that is involved as well, which is not seen on the CT. And again, here you can see the distinct abnormalities on the diffusion imaging that aren't visible on CT. We looked at this, as I said, in over 4,000 infants between 2006 and 10. One of the points I want to make is that these infants, to get into this registry, had to be stuporose or comatose or have seizures or undergone cooling therapy, which there weren't many before 2010. And interestingly, only 84% of them got any type of imaging. So I was like, wow, these babies are stuporose, comatose or seizing, and no one gives them any imaging of their brain. Like, it wouldn't happen at any other time of life, right? If anybody here today becomes stuporose, comatose, or starts to have seizures, someone's going to take you to the emergency department, you're going to be admitted, and you're going to get at least a CT, you know, but you'd get something. Someone would look at your brain in some way, shape, or form. So I was like, well, maybe those babies were just too sick to get any imaging, or they died straight away, and it was too hard. But actually, only of the babies who didn't get imaging at all, only 113 of them died. So that meant 15% of this cohort went home after that terrible illness with no diagnosis because no one had ever looked at their brains. I know that wouldn't happen here. But what happened to the ones who did get imaged? So half of them got an ultrasound, a quarter of them got a CT, and 2/3 of them got an MRI. And you can see the MRI tended to be later than the ultrasound or the CT. Abnormalities were very common, but in the CT, a lot of it was related to blood. And then you can see that when it comes to the important lesions, the deep grey matter, things like that were much more readily picked up on MRI than they were on ultrasound or CT. Now, maybe you'll say, well, great, but maybe the babies who got the MRI were different. The people were more worried about them. That's why they got an MRI, right? Otherwise, they just got an ultrasound. So we took the 651 lucky babies out of that cohort who got both a CT and an MRI, and we compared them to see whether there was systematic differences between the two imaging techniques for this. And ultrasound actually did worse than CT. But you can see for hemorrhage, one thing that people say a lot to me is CT is so much better for hemorrhage. Actually, MR was just as good for hemorrhage as CT.
This is no contrast. MRI without
Correct. Correct. No contrast. No contrast.
The CT was with a contrast.
The CT was not with a contrast. No contrast for either. So MR was good. And then look at the difference for deep grey matter and for stroke and for brainstem and cerebellum, all very important lesions, and MR was much superior to CT. The two commonest lesions that we see, and I know this is a very busy slide, and I am pleased to let you know that I have just held in my hand Dr. Volpe's new Neurology of the Newborn, the 6th edition. So it will be readily available in the next few weeks. It's completely redesigned, so we have increased from 27 to 34 chapters, and the HIE chapters are completely redesigned, separated with the encephalopathy of the preterm infant from that of hypoxic ischemic injury in the term infant. So they are completely, the whole book has had a complete redesign, rewrite. So this area of HIE is also completely rewritten. But the two commonest lesions that we see still are the deep grey matter lesions and these cortical or so-called parasagittal lesions. Here is the examples I showed you from Jim Barkovic's scoring system. These are pretty extensive injuries here. You can see in the basal ganglia, the thalamus, and the putamen with loss of the posterior limb of the internal capsule here. This is the so-called watershed. You can see posteriorly here and here, more extensive and global. I did want to make the point that optimizing MRI scanning is really important, and you should know, as you do, I'm sure, that MRI findings following injury are dynamic, and that diffusion will show us the injury early with the strongest contrast probably between day 1 and 4, whereas the conventional images need a longer timeline to evolve. And this is also changing in the setting of cooling. This was the original data that was shown. Looking at 16 hours, you can see some diffusion changes, but they become more extensively seen by about day 4. And then by day 8, now you are relying on the conventional changes. When you looked at this in relationship to diffusion changes alone, this data was published by Natalie Bednarek with our group based on comparison to earlier data from WashU. But I'm just going to go over these curves. The first curve here is warm babies or non-cooled babies. And this is the timeline of the abnormalities we see in diffusion changes in babies who have not received hypothermia. So these were babies who had a known insult around the time of delivery, so that's why there's not a lot of them. And you can see that it really falls pretty dramatically with a nadir around 24 to 4 days. Is when the lowest and most prominent diffusion changes will be seen. But then by day 7, you've pseudo-normalized. So whatever process was driving this, which we think is cell death, it has started to dissipate by day 7. And so then diffusion is not so useful for you out there. You've got to use the conventional. Now look in the era of hypothermia. We see something different. So now with hypothermia, we see that the fall is still as dramatic, and that the fall is still reaching its nadir between 24 to 4 days, but it is down for a much, much longer period of time. And we don't understand exactly what this represents. We think it may be a much more protracted apoptosis in terms of how much longer the brain injury is going on. It may also be evidence that there's a second window of opportunity for neuroprotection out here. But it does mean that sometimes if you image only once in here, there is still injury ongoing, which is why when you have a magnet in your unit and you can image maybe here and you see some abnormalities, you may want to image again out here, and you may even want to image again out here. Because now you don't have the barrier of taking the baby down and having the baby move and being not able to get access to the imaging time, and you can take the baby to see at multiple different time points how this injury is really evolving. Here is a kind of standard kind of textbook teaching about when you will start to see the changes now in the setting of hypothermia, in terms of when we start to see changes in conventional imaging, in diffusion, and in spectroscopy. So here's just an example of very extensive injury. This baby was imaged at 12 hours of age, but maybe this injury occurred much, much earlier than that. That this is very helpful for us in terms of our obstetric colleagues, who often, it is said, if they had delivered the baby 5 hours earlier, everything would have been completely fine, and why didn't they get the baby out? If you can image these babies very early and be able to see extensive conventional findings already, that is telling you that this injury is older than 5 hours, and we have done this a number of times now. This is more typical evolution of hypoxic ischemic injury. This is a day 2 imaging. You cannot see much on the T2, a little bit of swelling, but very prominent diffusion changes and restriction in the mainly in the cortical area here on the apparent diffusion map, mainly in this hemisphere. What this can evolve to by day 9 is so-called Wallerian degeneration, which is now you see that the signal has moved into the white matter, the corpus callosum, and the posterior limb of the internal capsule. So you killed the neurons, and now all of the axons that are connected to those neurons are going to die in the second wave of death. And that second wave of death takes a longer period of time before you will see it. But this presence of this posterior limb of the internal capsule diffusion change like this, or the loss of the signal on the T2, this is prognostically powerful for telling you this child will develop hemiplegia unless you intervene. Unless you start constraint-induced movement therapy and rehabilitation aimed at preserving function in that arm and leg, then you will lose that function, because this is what you will be left with after the infarct is gone. Loss in the thalamic volume, loss here, and you can even see some peduncular loss. So powerful, predicting outcome. These kids with these focal lesions tend to behave a lot like strokes. They may not have a lot of clinical signs in the first neonatal period. They may just have a little bit of weakness. They can be the kids that you may examine and think they look okay, actually not even offer them cooling, and then you'll be called from the postnatal ward when they are 12 hours old because someone has seen some focal jerking. That's often a kind of presentation for them. But later on they behave a lot like stroke children. They have a little impact on cognition, spasticity, clumsiness, and sometimes some specific impairments depending on where the lesion is. So we don't call past 12 hours, but we give everybody. So we have two mandates now. If you fall within the AAP criteria, you must be called. You have to be. It's like totally. Between anything outside of that, and that means between 34 and 36 weeks, softer criteria, any encephalopathy, or 6 to 12 hours. Then you can be called, but the clinician has to document that he has discussed or she has discussed with the family that there is no definitive evidence from randomized controlled trials. We think this will be a benefit. The risk factors have been discussed and the parents have agreed to have the therapy undertaken. So we just have a standard verbiage to document in the notes that we've discussed it with the family and that they have agreed that this is, outside of the bounds of the standard trials. And 6 to 12 hours is in that group. Outside of 12 hours, we don't offer cooling therapy. So the deep nuclear grey matter injury, you can see here, this is so-called mild, just one little spot there, moderate here, or severe injury. And none of us would miss the severe, but these moderate and milds are very difficult unless you have good high quality imaging. The other thing that is very important to look at is this myelination in the posterior limb of the internal capsule. This is very, very powerful prognostic sign. And if it is impaired, you might think you can see it. You see these little train tracks coming through here, these little bright white lines. This is the posterior limb of the internal capsule. It myelinates early so that the baby can eat, right? Use their corticospinal tract to use their mouth to eat. If it's impaired, you might have difficulty. If you're having a lot of difficulty finding it, we call that impaired. And if it's absent, you can see now the signal is reversed. Instead of this being pale grey and bright white, this now is bright white, and where the posterior limb should be is pale grey. Why is this important? Because it's very prognostically powerful. The injury in the basal ganglia, which is still common, if it is mild, like just that single spot that you saw, there is still a 10 to 15% chance of cerebral palsy, although it is usually only mild to moderate and not severe. If the posterior limb of the internal capsule is normal, the child will be walking by 2 years. But if it's equivocal, some will be starting very late, and so it's important to evaluate that. And then these children with mild injury don't escape a risk in all the other areas, but their risk is less than if the injury is more severe. So here is the moderate now your risk of cerebral palsy is between 60 and 75%, and many who have an abnormal plic will have significant cerebral palsy such that they won't be walking by 2 years of age. Many of these children will have feeding difficulties, impairment in speech and language, and significant risk of intellectual and developmental disabilities. But if they get into the severe category, which is very important to know about in the first 24, 48 hours of life, because these are the children where multiple disabilities across all domains are likely to make their lives extremely challenging for their families. And these are the children that you'll see with very severe spastic quadriparesis who have inability to be able to communicate and inability to be able to feed by themselves and will end up with very long-term challenges. And if you know this early on, then conversations can start very early with the family about what is the best care, because usually these severe babies will be ventilator dependent at least for the first period of time in the ICU. This again is what a posterior limb of the internal capsule should look like. These two bright train tracks coming through here, and this is when it has been lost, you can see here. And Mary Rutherford was the first to note the strong association with just this single sign with the presence of cerebral palsy, and that if the plic was absent, then the chances of an abnormal outcome were universal. If the plic was present, the chances of universal good outcome was present, except for 4 children who also had extensive white matter damage. Now we can also do very fancy things, particularly for infants, and this is an infant with a middle cerebral artery stroke, as you can see here, and on the T2 with the loss of the cortical ribbon and the swelling. We can look by diffusion tractography at the posterior limbs of the internal capsule, and you can see the impairment in the size of this compared to this. And this is some of the information that is coming down the track in terms of being able to predict motor risk. We also use spectroscopy, and this is a baby who had significant basal ganglia injury, and on day 1 you can see there's a doublet here of lactate at 1.2 to 1.3 parts per million. The NAA, which is a measure of neural integrity, is still very good. But now we scan 10 days later, the lactate has gone, but the NAA has dropped because we've lost neurons during that time period. It has also been shown that spectroscopy is very powerful, particularly in terms of its prediction for outcomes. You can see here the sensitivity and the specificity for NAA, but certainly early on, lactate over NAA can be important. Does hypothermia make a difference? As I said before, this is probably the best data. These are the risks or the odds ratios for injury after hypothermia. This is, in other words, a 65% reduction in the severity of the brain injury on MR in each of these areas, whether it was the basal ganglia, white matter, and maybe a little bit less in the cortex after hypothermia compared to infants who did not receive hypothermia.
But that were not the mind in the Toby trial.
Correct.
Moderate to severe.
But
Until don't know about mind.
right. But what I'm saying, I think, is that the lesions that were described in the moderate babies are the same lesions we are seeing in the mild babies. The encephalopathy exam is just not so powerful in terms of its prognostic.
Would you see, what, I go over what Francis said, would you see any lesion just from cooling a healthy baby?
So we,
No one has done that.
no, we have never done that, but we have cooled a lot of babies who didn't have any injury, and we didn't see something that would, like, I mean, from hypothermia alone,
Yes.
I don't know what you would expect to see in terms of a pattern.
Did you see any problem?
So in animal studies, the only thing that has been done has been injury models with hypothermia.
But not a healthy lamb with hypothermia.
No.
There's a MRI with just cooling.
No, because I don't know what you would be looking for. What type of abnormality would you be looking
I
for?
want to be sure
Yeah.
that just cooling somebody who maybe not needed it, I don't know how many.
If you reduce metabolism in the brain, I don't see why you wouldn't see abnormal signals of MRI.
You reduce metabolism in the brain, but if you look at animals who hibernate every year, they don't have evidence of brain injury with hibernation every year. Do you know what I mean? I don't know what you would be specifically looking for in terms of an effect. If there was cold stress that was a marker of stress and you had other inflammatory co-processes that you were upregulating, but even, I mean, the things that hypothermia does is it downregulates metabolism, it downregulates neural activity, it downregulates inflammation, and it downregulates oxidant stress, if you like, in terms of the reactive oxygen species. It downregulates excitatory amino acid release so that you are abnormal. But I'm not sure what types of... Do you see what I mean?
Your answer related to hibernating animals is smart. I'm not sure that it's applicable because, for instance, I was very much interested in hibernating animals because I was doing lots of research on bones, and no one knows why bears don't have decreased bone density after a whole summer, after a whole winter, when they don't move at all. Hibernation in hibernating animals is very different from...
So I agree. I mean, I don't think we want to be cooling healthy babies.
No.
So the problem with this, I suppose I'm trying to point out, is just that I don't know when I see the baby I deem as mild, that I can distinguish the injury that baby has from a baby who is moderate. And so the problem is not whether the baby is normal or has injury. The problem is my tool for saying who has injury is so crude that I don't have a better biomarker to define who has injury. And the risk of them having injury, by the look of it, is about 75% in either category. And the nature of the injury is the same in either category. So, I mean, you could say, if I'm not going to offer it to the mild, I shouldn't offer it to the moderate either, because theoretically they have the same disease. It's just my clinical biomarker is poor for distinguishing them. Or you could say, you know, I will offer it to them all and I will continue to monitor by the MR and by the tools that I have now available to me what injury is truly present in this individual baby alongside my clinical markers. I think this is the problem that's hard. So I agree, I don't think we should ever call healthy, but I can suggest to Alistair Gunn he calls healthy lambs. I'm okay with the lamb.
Francis, I think that we all stand in front of these babies that are, we ask ourselves, are we going to cool them or not? We put them on AEG, we test them every hour to see if they're encephalopathic or not, and then at 6 hours of age we have to decide if we're going to cool them or not. And sometimes we cool them, sometimes we don't. Sometimes we cool them and then we have a normal MRI, and if we don't cool them, usually we don't have an MRI and we don't know what's going on with them. And I think this is what you bring, that some of them do have some kind of injury that...
Well, 30% of them are having significant disability in the small numbers that have been followed up.
In your hands, because when I do a clinical examination, it's completely different.
Right.
Maybe I choose much better than you and maybe not.
Right.
But it's impossible to know because it's not objective. So I think this is the point that you're making. And not try going and cool normal babies, then you need to cool every day at least 3 babies. Because we have a lot of babies with a pH below 7.1.
You know, we know that morphine can cause apoptosis, and if all these babies are on morphine, do we know whether this is contributing to some of the findings?
So it's very interesting because the data for morphine is in the setting of healthy, completely healthy babies. When you look at any hypoxia model at all, even the mildest of model, morphine's protective, as are all the anticonvulsants. So all the anticonvulsants cause apoptosis, apart from perhaps levetiracetam, in the setting of completely healthy, unstressed, anything babies. You give them anything, even the mildest hypoxic insult, and they are all additive in terms of neuroprotection. The reason I think morphine is so important if you are going to cool, and that decision is the one that's so tough, is that in at least the piglet studies that Mariana did, when the animals weren't relieved of the stress, the cold stress associated with cooling, there was no neuroprotection. In the neoneuron trial, which was the only one that had morphine routinely associated with it, they saw a 75% reduction in death and disability, which is a much bigger effect.
That turns my question upside down. But if morphine is neuroprotective in these babies, then perhaps even if we decide not to cool, they should all be given morphine.
Well, some people, I mean, the Cork group, who led a lot of this stuff early on, the Cork group used to give everybody 40 per kilo of phenobarb, right, based on the Hall trial that showed an improvement in outcome. Yeah, and so that's the same philosophy. You are down-regulating metabolism, right? But we think phenobarbital is bad for the brain, but targeted, just like monitoring for seizures, targeted treatment, you know, just at that one time, not necessarily for any further doses. But we use extremely low doses of morphine, and for us, even in our preterm population, we know if our morphine dose doesn't exceed 2 milligrams per kilo, total dose, then we don't seem to see any adverse effect on the cerebellum, which is where we see the most apoptosis.
That was a question. So it's frustrating to think that we are able to predict with ultrasound findings. But has anyone actually had a look at the resistance index and the resistance index flow changes that happen in the first week?
I think you could, I think it has not been well looked at in the setting of cooling. I think the problem with the data with the resistive index is exactly the same as is with the timing issue, and that the timing, I think, is so diverse in these babies. And if you had, you are in the best place now in the world to be able to carry out that study in parallel and do MR and the resistive indices together alongside EEG, AEEG, and get a complete data set, because no one has done it.
Stefan, you can start.
Can I ask why you presented a very compelling argument showing the radiological progression over each, almost from day to day, in babies with injury. I'm not clear though on how management is changed by doing such early MRI studies, because basically all the guidelines that you've presented are still based on clinical. The guidelines of when to start cooling are based on clinical considerations.
Correct.
Certainly not radiological considerations.
Correct.
So what's the difference between scanning at day 4 or downing at day 14?
So
obviously prognosticating is important, but
Yeah.
2 weeks of age is also a good age to prognosticate.
Well, I would challenge you with that in two ways. One is you don't know what you're treating by the time you've got to 2 weeks. So 14 days you've been running blind with what you're actually treating. So there's three things I put with that. First is at 24 hours, it's really nice to know what you're treating in terms of being able to guide. Am I going to continue to monitor with EEG? Am I really worried about seizures? If I see that I've got cortical lesions or a particularly larger lesion than what I thought I had, then I really do want to keep going. And so early imaging can help you to know what it is you're treating. It can also help you if you are considering that there's a severe baby and I need to consider redirection of care. I know that I've got severe basal ganglia lesions, and I know that that's what this is going to do. By 4 days, you'll have clear delineation of what you're treating. You've rewarmed your baby by that point. You know that, am I expecting this baby to feed and go home in the next few days of life? Because to parents, that's what they want to know. They want to know, does my baby actually have brain injury? And if so, what should I be expecting like this week, next week, in 2 years' time? And you can say at 4 days, so at 4 days to me, there's still some babies, there's 15% who won't have fully evolved their injury by 4 days in terms of the fact they can look pretty good, but there will be some mild injury. But no one goes on 4 days from negative to bad, to really bad. But at 4 days, you can be pretty reassuring then to families to say, look, there's very little or nothing here. We do have to do one more imaging set at 2 weeks and whenever it is to make sure that everything's good. But to a family to wait 2 weeks after being given a treatment for brain injury for their babies it's pretty hard for them. And that way your expectations of, you know, am I expecting this baby to get feeding straight away? Are they going to require more time? Do I want to start rehabilitation? Am I going to talk to the therapist now about the fact that I'm expecting this baby to have motor deficits affecting the left side? I want to start constraint-induced movement therapy today. I'm going to put their little arm and leg inside their little suit for half an hour morning and night. You know, you're essentially, you're running a neurocritical care service where you're targeting your treatments for both acute. Now, the final thing I'll say is there's another string of treatments that are about to launch, right? So high dose erythropoietin, melatonin, insulin-like growth factor. We're doing the umbilical cord stem cell study ourselves at the moment with Duke. You know, there's a whole bundle of these studies that are the next phase, plus the cooling studies. And so you're going to want to know, should I be continuing erythropoietin in this baby, right? If your baby's got absolutely no injury, you know, do you think that it's wise to, I mean, you know, you have to make that call, but you will know what you're treating. And I think that we need guidance at the moment. We can't, it's not just about predicting outcome. It's really about knowing who I'm protecting at what phase in their injury. If your scan at 24 hours is starting to show early atrophy, even though your baby was encephalopathic and you were cooling it for all the right reasons, you know that most of the injury was done some time ago and that your treatment's probably not going to be altering anything about this baby. You're not going to be expecting them to turn around and get a lot better.
Let me ask a couple of questions about the actual interpretation of the MRI, the reading. If I understand correctly, you're usually looking for one of the conditions, or there's sometimes you look for some of them. So how long would you spend typically doing the reading to come to a conclusion?
Put it to my radiologist.
I mean, I think that the classic looking for the flicks and such is relatively quick. So, you know, I think a grossly normal study would take just a handful of minutes. If there's a high degree of suspicion and you're starting to look for very subtle things, it could take a half an hour, 45 minutes working with clinical colleague. But typically, reading them in isolation is a relatively quick thing.
So that would be for the diagnosis. How about the follow-up? Because then you have to bring the images from the previous studies and compare.
Yeah, and so, you know, I think that's what we do every day in the clinic is that we look at serial images, and so some things become very evident, actually become easier to interpret because if you see Wallerian degeneration over time, for example, it becomes clear that that cerebral peduncle is getting smaller. We have increased signal on the diffusion or the flare images. So a lot of times it's easier to look at serial images than it is to look at a single snapshot. And, you know, to the point of 4 days versus 14 days, you know, I think that in a utopian kind of scenario, we might be able to look at this almost as daily, like a neck watch, you know, where you do daily belly films or you do daily chest x-rays. You know, there's a way to do a very quick screen. That will also inform what we're doing in terms of monitoring treatment course. But the other point about early imaging is also, you know, Terry showed a slide where there was the case of hydrocephalus or there's extensive other disease. You'll be able to look at mimics and then exclude a whole path of treatment. And you know that's and you know the point of the adults. If any of us sees, we would immediately go looking for a brain tumor. You know, you wouldn't leave the hospital without that. You know, it would be really wonderful we could offer that.
So would it be more the detection or the quantification where you would need most help? What would
All of
be
the
the most?
above. I think.
So I mean, in
No,
the
no,
ideal
I'm not
world,
trying
you
to-
press
no,
the
I'm not
button
trying
and
to-
you get
no, I'm not
an
trying to be glib
automatic.
about that. Think about the EKG
Right.
approach. If you have a big hospital like this, and it's staffed 24/7, but your most senior people aren't here in the middle of the night.
Okay, let me keep going.
Yeah, that would be the kind of thing, right?
So just to show you whether you're called or not called, that the predictive value of MRI for neurodevelopmental outcome is very powerful. And you can see here, it doesn't matter whether you're called or not called. So these imaging recommendations were made in a chapter that we wrote for the latest edition of Neonatal Encephalopathy and Neurological Consequences for the College of OBGYN, and we did put in that head ultrasound should be used, MRI should be used early to delineate injury on diffusion, and it's helpful for estimating the timing, and then follow-up imaging between 7 and 21 days, but at least a week after rewarming to make sure this. But these were guidelines that we wanted to be adopted widely. So they weren't in the places that had luxury access to imaging. These are places that were fighting tooth and nail. And as you could see, this was written on a background where I knew 15% of babies didn't get any imaging at all, let alone trying to get them all to the MR twice. So can MRI improve outcome? I think it can, as I said, confirm the diagnosis, explore the timing of the injury, and I think this is really important because it can provide restful peace to a family. And I hear the most pain from families when they say, I should have told that obstetrician the baby had to come out now. I just, I should have been yelling at him or her to get the baby out now. The family blame themselves that they should have done something differently. And to be able to say to them, look, the MR shows that this happened a day or two, and the baby, and people joke when I say this, but I actually believe it's true. We have a lot of late pregnancy stillbirths, and probably so you do in your hospital too, but you don't hear so much about them, right? Because they're managed by our perinatal colleagues. And I think there's a lot of those that get close, that are so-called like ulties, that nearly die from cord incidences or other things, and then come back and survive, and then say, it is absolutely terrible in here, I need to get out, induce labour. And so we have these near misses that go straight into, provoking labour, and then they don't handle labour very well because they've already had a brain injury, and then we get the consequences of a baby that's down. But it wasn't acutely prior to delivery that it all happened. And, if that was to happen and families could be reassured that it looks like it was 24 hours or 36 hours before delivery, it's really helpful. We need to be able to define the presence of any injury as hypothermia indicated, and obviously we've talked about, prognosis and prediction. So to me, at least in the term infant, I think that MR is very powerful to understand whether this baby's behaviour has had a matched reflection of what injury may have occurred, so that we can target our protective therapies at the right time to the right patterns of injury, and then ultimately send the baby for rehabilitation. I'm going to move on to a more controversial topic, the MR in the preterm, and I'm going to touch, it's going to be briefer for those of you that have to go, I know, to define brain injury and alterations in brain development, and obviously the prediction of outcome is going to come up in here. The forms of brain injury, we all know IVH is well detected on cranial ultrasound and is really defined by these 4 gradings still. I don't know whether it's good or bad, but this is data over 20 years from the network, the Neonatal Research Network, showing that at least in babies between 22 and 28 weeks of gestation, we have made no impact in this condition, that we have almost identical incidences of this condition as we had back in the mid-90s. And it's not just because we're resuscitating smaller babies, which is what I hear all the time. If you look by gestational group, we have made almost no impact. And that's despite the fact that steroids, at least in the US, went from 24 to 87%, and intubation decreased from 80 to 65%. Now, obviously, this is prior to the era of the start of delayed cord clamping, so whether we will start to see some impact from that, we don't know yet. What are the causes? Well, there's causes we can't do anything about, which is your gestation and your vascular immaturity, and whether you were exposed to chorioamnionitis, and whether you needed resuscitation or had low APGAR scores. I mean, hopefully we can make the APGAR scores as good as we can, but we can't really impact. But we can impact on some of these other things, potentially, in terms of particularly the hemodynamic area. most of which we don't monitor at the moment, right? We don't monitor what's going on in this whole domain. So this is the current kind of very confusing, long but important paradigm I think that IVH sits with at the moment. We think it is an ischemic reperfusion injury, with most of the ischemia occurring perhaps in the first 12 hours followed by reperfusion, all on an immature cerebrovascular regulation. And what do I mean, the risk factors for ischemia? Well, myocardial dysfunction and immaturity, which most of us don't even look at because most of us don't do targeted echo or can't. There's the presence of compromises to intravascular volume, and then there's our friend the duct, which I know you have interest in here too. All of these are affecting cardiac output and therefore cerebral perfusion. Then there's ventilatory instability, hypocapnia, the giving of surfactant. So this leads to cerebral ischemia, injuring of the germinal matrix, and then guess what happens at around 12 to 24 hours? We go, oh, look at that blood pressure. We better put up some dopamine, give a few fluid boluses. We start to get into a bit of trouble with our ventilation. We see the CO2 fluctuating, and we might decide we want to treat a duct and give something that could potentially close the duct and could do some changes. And all of these things could be associated with marked fluctuations in cerebral blood flow, and in particular, particularly with increased systolics, which we often don't look at when we've got dopamine running, we can have these reperfusion injuries. On top of that, increasingly we recognise the impairments in cerebral venous drainage and cerebral venous congestion, and particularly with continuing cardiac preload dysfunction. So this combination, most of which we don't measure cerebral perfusion, we don't measure what's going on with the cardiovascular system, we think is contributing then to the rupture of the germinal matrix and the occurrence of the IVH. So ultrasound, very classic look, as all of you know, from grade 1, some blood now into the ventricle, the dilatation, and then this blanching up here, seen more easily into the parenchyma. This is the classic evolution of the IVH, day 1, day 3, day 5, and you can see nothing much, maybe a little bit visible here, and then more prominent bilateral germinal matrix hemorrhages, and now the ventricle being filled with a secondary obstruction of the germinal vein coming down here with the medullary veins then rupturing. And you can see that here with the blood here on MR and this immature brain, and the rupture here with the parenchymal venous infarction from the obstruction to these medullary veins draining. So obviously to prevent this disorder, we have to prevent the obstruction in terms of the large intraventricular hemorrhage. Now MRI I find extremely useful in the setting of so-called grade 4s or parenchymal venous hemorrhagic infarctions, and here are 3 different examples of a parenchymal venous hemorrhagic infarction. And I think delineating the size of the hemorrhage should be able to be done easily with ultrasound, but for some reason you can see a lot more. And the other thing I can see and get a good look at is the cerebellum, which often can be at risk. It has its own germinal matrix, and it often can undergo rupture in the cerebellum at the same time. But you can see the difference in the size here very clearly, and the impact on the underlying basal ganglia, which is important for prognosis. This also has basal ganglia injury, whereas this much smaller parenchymal lesion was still called a grade 4 on the ultrasound. You can see it's got minimal to no injury in the basal ganglia. So being able to delineate the difference between the related and particularly what the other hemisphere looks like as to whether there's abnormality in the other hemisphere, I find really prognostically helpful in discussing with the families. We had one family, the family that owns this image, who wanted or had been told, he was an engineer and she was a developmental psychologist. They'd been told their baby had a grade 4. They looked up all the literature on grade 4. They asked if they could take their baby off the ventilator. We said, well, we have another way we could look at the baby's brain, and I can tell you she's a beautiful 4-year-old who has had a little bit of stiffness in her arm, but otherwise is running around and doing everything normally as a 4-year-old would. This has been looked at by Linda de Vries's group in this beautiful publication here, the largest number of published parenchymal venous hemorrhagic infarctions, showing most are in the parietal area. And of those who survived, so there's already some selection bias, to more than a year, there was 102, and about half of them had some degree of cerebral palsy. But of that, a significant number, 75%, was just affecting the upper limb, and half of that was only mild. So although I see black crepe hung uniformly when anyone hears the term grade 4 IVH, I think we have to be very careful about the way in which we prognosticate this. And just showing that most of the other problems outside in terms of cognitive related to those with frontal and temporal lobe lesions. We can define beautifully by ultrasound the presence of post-hemorrhagic ventricular dilatation, and we all wait for the Elvis trial results, which I don't think are going to give us the answer we want, unfortunately.
Yeah, they presented it in Killarney.
Do they?
So, yeah. So the results.
Cerebellar hemorrhage, to me, has been prominently picked up on MRI, much more so than we've seen on ultrasound. Here is a baby who did have a cerebellar hemorrhage seen here on the ultrasound, and you can see the cerebellar hemorrhage here. But most ultrasound studies, it's quoted as only 2 to 8%, whereas if you look at those that are doing routine MRI, around 15 to 20% of routine MRI studies will show cerebellar hemorrhage. And it seems that the smaller cerebellar hemorrhages are the ones that are missed on ultrasound and probably are important. But we're still investigating that. And it may be the smallest babies have got the highest risk, both for high-grade IVH and for cerebellar hemorrhage. White matter lesions, you're all familiar, cystic and diffuse, diffuse being either these focal punctate lesions or loss of white matter. The risk factors, particularly ischemia and inflammation, that of maternal or infant sepsis. What does it look like on ultrasound? It's usually defined as this echo density that is equal to or greater than the choroid and is present for greater than 7 days. It's challenging to diagnose PVL on ultrasound. Many groups now have shown poor correlation between MR and ultrasound, and it's also been shown that there's a poor consistency in reporting even in the setting of cystic PVL, which I find even harder to believe. But white matter lesions, it's hard because lots of people call them different things on MR. This is Stephen Miller's definition, just these white matter dots. You either have a little dot, a bigger dot, or many dots to distinguish you. We brought in a scoring system that took into account loss of volume as well as enlargement in the ventricles. So you can see here's a single dot, or enlargement of the ventricles suggestive of white matter atrophy. You can see here how posteriorly the white matter is just about touching the cortex or the ventricular dilatation here. And this was common in our preterm population under 32 weeks. At least half the babies had this. This is more significant, moderate white matter, more spots and dots, always associated with ventricular dilatation. But you could also have this really significant loss of volume of the white matter without the spots or dots. And then obviously the severe lesions were always associated with cystic changes, but often they had spots and dots or gliosis as well as the cystic changes, and they always had loss of volume. Look how the cortex is just about touching the ventricle in all of these regions. Diffuse excessive high signal intensity in the white matter. You can see here's a standard white matter T2, and here's a bright white matter T2. This has been reported to occur in up to 3/4 of premature babies at term. Does it matter? We looked at this with Hirayuku Kitakoro in 160 of our babies, at least to 2 years. We found no association with any impairments, either their average Bailey score, impairments, average motor score, or presence of cerebral palsy. We are following those kids up now at 7 and 13 in relationship to this data as I speak. But what about the other injury forms? What did we find about just if we knew that injury alone, could we predict outcomes? So we looked at 340 kids, and this was the white matter scoring, grade 1, grade 2 more significant, grade 3 linear scarring, grade 4 cystic. And we also looked at IVH using a sort of standard, and then cerebellar hemorrhages, small unilateral, small bilateral, large unilateral, or large bilateral. And what did we find? Well, the first thing is that a lot of our premature babies didn't have a form of brain injury. 220 out of the 340, or 2/3 of them, had no form of brain injury that we saw. And look at their Bailey scores. So 86 for cognition, 89 for motor. 13.5% of them had significant intellectual disability, and 5% of them had cerebral palsy, and they didn't have any form of injury. So clearly, something else is going on. It's not just these forms of brain injury, despite the fact that when I started, I thought as long as you got rid of all of these, everybody would be fine. So clearly, that's something else, and we can talk about that if we want to. But when you did look at these severe forms of brain injury, then you did see that the most severe forms, even though they're not common, really were associated with pretty stark deviations downwards in terms of motor scores for the PVL and cognition, high risks of cerebral palsy for those high-grade lesions. So what would term MRI have to offer then? You know, you can probably see those forms of brain injury on MRI, and there's been a lot of discussion about this lately in the literature, because are we just causing more anxiety to our parents by doing these MRI scans? So this was provoked by a single baby from the Montreal group who was born at 25 weeks. Her twin sister died. Family had a very stressful NICU course, and an MRI was undertaken as routine care. Now, I'll tell you the mistake that was made was the parents never knew the baby was going down for an MRI scan. No one had spoken to them and informed that it was part of their standard practice in their unit, and the reasons why it was important for their baby to have an MRI and what it might pick up and how that could be helpful. And so the parents the baby came back and was found to have a moderate cerebellar hemorrhage. That was new information to the family, and they were told it, I think, by either the intern or the medical student, or someone who transmitted the information back without a lot of associated knowledge to reassure the family about what the next steps were. So the family, who were very intelligent, then ravaged the literature to find Kathy Limperopoulos' papers all about how their child was going to have autism, and that it just wrecked them. And so they wrote this piece saying, you know, that they didn't understand why this was being done, that now their daughter, who was 2 and doing very well, didn't have this, and they had spent their entire first 2 years of life wrecked with anxiety that she was going to be affected, and that there was a tenuous link at best between MRs and premier outcomes. And some parents would prefer to remain blissfully ignorant, especially if there's nothing medically tangible that they can do. So this was part of the provocation of, why are you doing this? You're torturing these families rather than informing them. So another piece that was written by Keith and Annie, who had been involved with this family, was that considerations for undertaking MRI at term include focused follow-up programs. So if you've got limited resources and you need to focus, to select babies for early intervention services, to do quality control about the outcomes in your own infant, to prepare parents for the future, and for research to better understand the effects of prematurity. A normal term MRI has a high negative predictive value, which it actually does, and almost every study has shown that at least 25 to 30% of our very preterm babies have completely normal MRIs, and that those children go on to do as well as any term-born child. But a much lower negative predictive value for developmental delay. An abnormal MRI has a positive predictive value for either cerebral palsy or developmental delay, but it varies. So how much does it really help to know the results of the term MRI for a specific baby? That was provoked even more by the American Academy of Pediatrics doing this choosing wisely in newborn medicine thing, where they got a lot of and I'll be provocative to say, a lot of their friends together in a room to say, what treatments do you think aren't really making a difference? And the things that came up were treating acid reflux, doing sleep studies, and, oh, by the way, doing a term MRI, because it's never been shown that doing a term MRI actually improves the long-term neurodevelopmental outcome of a preterm baby later. And they did clearly say findings on term equivalent MRI correlate with neurodevelopmental outcomes at discharge and at 2 and at 5 years. They forgot to say that nothing else we have does, that it is the only thing that we do that actually predicts outcome. And then they said there's insufficient evidence that it improves long-term outcome. They also forgot to say there's never been a study to test whether doing an intervention like this improves long-term outcome. The only study that even has the capacity to truly answer this question is a study that's being done at the moment in London. And what they did was randomise babies at term to either a term equivalent ultrasound or a term equivalent MRI. And the first thing they did was say, well, it's going to make the parents more anxious to know everything from the MRIs. That was their first hypothesis. And the second was that the knowledge wouldn't improve outcome. So the first thing that they did was they showed that the parents who got the MRI were less anxious than the parents who got the ultrasound, because the parents who got the MRI, they went through the MRI with them, they showed them everything that was there, they told them what they knew at best, and when they discovered things like Marin's cerebellar hemorrhage, they told them, this is what we're going to do, we're going to put you specially, we're going to be following and tracking, and you're not alone, we're supporting you with this extra finding. The parents with the ultrasound reported that they still didn't really know how their baby's brain looked. They'd been told it was a pretty limited study to be able to fully define abnormalities, and so they were still anxiously watching their child to know what the future's going to hold. So the first thing would be reassuring to us that doing an MRI is not provoking anxiety but may arrest anxiety. In terms of the neurodevelopmental outcomes, I think I don't know how the knowledge that they gained from the MRI is being used to target rehabilitation services, which is what you'd need to do, right? You would need to say, okay, the information I get from the MRI now is going to alter what I deliver into the home in terms of rehabilitation. If I find a lot of white matter injury, I'm going to go after motor development, and if I find a lot of temporal lobe disturbance, I'm going to go after language and regulation, and if I find, so you'd need to target based on the MR to believe that you are really going to improve outcomes. So we may not know that yet. What do we know? As I said to you, we do know, and here are all the studies that have compared ultrasound to MR for at least motor outcome, all showing overall that MR is much superior, and particularly the sensitivity, as you can see here, is significantly higher across a large number of studies. We actually think it's really important when you look at the MR to look at it in a systematic way, and we have a systematic scoring sheet, and we have actually taken that systematic scoring sheet with our neuroradiologists and incorporated it into a standardised reporting form now that comes back with every one of our term infants. And our neonatologists have got used to understanding and reading and interpreting this. And we look at this in several ways. The first is to look at the biparietal width, so that gives us a measure of the brain volume. As you can see here, there's a fairly good correlation between that simple measurement at the level of the cochleas of the width of the brain against brain volume. And the second is the interhemispheric distance. As you can see here, a lot of our babies have, I like to call it room for growth, where the brain is not filling the skull, and I don't know, some people have said, is this atrophy or is it just impairment in growth? I don't think they were big and then they shrunk. They just never grew to fill the skull. And so you see this, and we know that when this measurement is above 4 millimetres, that's when it is pathological, and it's a very simple measurement. Our scoring system looks at the white matter. We look at cysts. We look at focal signal abnormalities, we look at delay in myelination, we look at thinning in the corpus callosum, dilated ventricles, and the size of the brain, and you get scores for each of these, and then we add the score up to give you a total score for your white matter. We also have a score for your cortical grey matter and in your deep grey matter and your cerebellum, and all of these have some degree of signal abnormality and some degree of growth or volume. And that combination to us is the two important pieces to put together. Here is some of the volumetric measures. We already looked at the biparietal width and interhemispheric distance. Here is the measurements of the corpus callosum, which are the least reliable or reproducible by us. The measurements of the ventricle and the cerebellum, which is done on the same, so these are two different slices, but it's pretty quick to do this. Our guys do it really quickly. And the area of the deep grey matter. Does it matter? This is the latest data that we just published looking at this scoring system, and this is the relationship to 7-year-old performance, 7 years after discharge, IQ, spelling, motor, reading, math, lower being worse, and strengths and development higher being worse. So if you look at the white matter scores, as we had shown previously in the New England Journal paper, we still see a persisting effect of white matter abnormalities on outcomes, particularly in the moderate to severe kids. But if you look at cortical grey matter, we don't find that that scoring is as robust. But look at deep grey matter and cerebellum too. So we focus a lot on the white matter, which is important in our babies. But when we look at the system, the deep grey matter and the cerebellum are also really important. So when you combine them all to our global score, the global score is really predicting consistently more disturbances in brain development having impacts 7 years later. So preparing families for the risk, not just the motor risk, but the risk across a broad range of academic performances. So I know I'm going to talk a little bit more with some people about how to do imaging, but I will say it's really important that neuroimaging is only as good as the person who writes the order for it and gives the details about what's gone on in the baby's course, about the type of acquisition that is acquired in terms of the quality of the scans, the person who's interpreting it with you, the neuroradiologist, and their knowledge of these types of lesions, and the person who's talking back to the family about what the findings are and what they mean. Neuroimaging is just a tool. It's not an answer. It's a tool for you to apply to a question to provide you with data that you translate into knowledge that you can then inform with. In the clinical aspects for the preterm infant, what do we do at the moment? We do cranial ultrasounds pretty frequently now between day 1 to 3, day 7, and then weekly up to about 30 to 32 weeks, and then again at discharge. We do an MRI at term equivalent, and I'm happy to share our protocol. We have quite a range of reasons. Any abnormality on ultrasound at any time is one way you get weaned in. If you're under 28 weeks, you are universally in. And we have found improved sensitivity for cerebellar hemorrhage, white matter lesions, and for brain growth. And we think it has predictive power for all the outcomes that, of course, remain in evolution. And maybe combining this data plus other data about the clinical course, although we've found the clinical course not to be as potently predictive as we would like, will be helpful in the future. In terms of its research potential, it has provided for us incredibly unique insights about the impact of many of the exposures of the preterm infant, including pain, stress, narcotics, infection, and now we believe the presence of the positive experiences of nurturing and downregulating anxiety and stress in the preterm infant, the positive impact of maternal voice in regulating and downregulating and improving particularly language development areas of the brain and improving the nurturing, and the impact of breast milk exposure as a positive impact. So you will quickly evolve from what may start as a clinical program into seeing and wanting to answer more and more research questions as you look at this population. So do I think MR improves outcome? I hope that I've at least said that you can't attempt at the moment to improve outcomes until you can define what you're dealing with. And the only way you can do that actually is with this form of imaging, because then when and if these different types of targeted treatments come along, then you can be targeting the right treatment to your babies in the right way. If you don't know where you're starting, you have no idea what you're even intervening in. So with that, I think this is what we all aim to do, which is send home healthy infants and healthy brains and healthy families. And I think you have a very unique opportunity here now with such a wonderful tool right next door to be able to apply it and then refine it depending on what you find and how it informs your clinical decision making and how it informs your clinical management, and study it as you're doing it. Study the impact on your families as you start to move forward using the tool, whether you start to see differences. But in your preterm population, I'd challenge you, you may not know what your brain growth is like at the moment. And unfortunately, your head circumference won't tell you, because head circumference does not seem to be as useful as being able to measure the brain growth. Wouldn't it be interesting for you to know, how does the brain growth relate to the baby's body growth? And are we doing a good job with brain growth in our unit or not, as we start to care for more and more tiny babies? So with that, I will finish to see if you have questions.